Dr. Nisha, are you ready with your presentation?
Good afternoon all. So I will be talking about clinical features, trends of antibiotic resistance and outcome in multi-drug resistant Pseudomonas and non-multi-drug resistant Pseudomonas keratitis. There are no financial interest. And as we know, Pseudomonas is one of the most common gram-negative organism associated with microbial keratitis. And we define multi-drug resistant strain as those who are non-susceptible to one or more agents in 7 of the most commonly used class of antibiotics. And in recent years, an increasing trend of multi-drug resistance was noted. So we conducted retrospective analysis of 108 patients over a period of 10 years from January 2014 to December 2023. And we studied the medical records for demographic data in the form of age, gender, and any etiological factors like trauma, contact lens use, poor ocular surface. And baseline best corrected visual acuity, size of ulcer, and hyperpan was noted. And any associated ocular comorbidity like non-patency of the nasolacrimal duct system was, and also studied the antibiotic sensitivity. Then any intervention in the form of medical or surgical or any complications and outcome were noted. So graded the corneal ulcer based upon size into 3 categories: less than 5 mm as grade 1, 5 to 8 mm as grade 2, and more than 8 mm as grade 3. So we conducted the antimicrobial sensitivity test on the disc diffusion and Bitec system, and strain those were intermediate susceptible were considered as resistant. So there were 67 patients in multi-drug resistance group and 41 in non-multi-drug, and there was slight male preponderance in both groups. So in study we found that trauma was the most common risk factor in both the groups, and the more severe grade 3 ulcers was found in 39% in MDR group and 32% non-MDR group. So this is a picture. A and B are of multi-drug resistant, which were sensitive to Ciplox and healed completely with corneal scar. And picture C and D are again of multi-drug resistant, which was sensitive to ceftazidime. And after antibiotic susceptibility report, we started on ceftazidime, but eventually it worsened and need therapeutic keratoplasty. And in picture E, which is also a grade 3 ulcer, but it was NMDR and healed completely with ciprofloxacin only. So based upon initial gram staining and smear findings, patient was started on cefazolin and ciprofloxacin combination, and later on based on antibiotic susceptibility report and culture report, additional ciprofloxacin and imipenem were added. So surgical intervention in the form of TABCL, therapeutic keratoplasty or evisceration were noted, but there was no statistical significant difference in both the groups. There was a comparatively more number of therapeutics in MDR group, which can be due to low threshold. And when we compared the functional outcome, again the results were not very significant, though there were comparatively more number of failed graft in MDR group. And then we compared the antibiotic susceptibility trends in the initial 5 years with the last 5 years, and then a trend of increasing antibiotic resistance was noted, especially to chloramphenicol, piperacillin, and colistin. So in conclusion, Pseudomonas keratitis, which is already a very difficult and devastating disease to treat, and become even more difficult when the organism is multi-drug resistant. So as we noted, the increasing trend of increasing resistance because of more use of broad spectrum antibiotic, but in our study, clinical outcomes were comparatively same in both the groups, which can be because of starting treatment based upon antibiotic susceptibility report and comparatively low threshold for therapeutic keratoplasty in multi-drug resistance group. Thank you.
So I understand that even though you saw some piperacillin resistance, you've not seen any imipenem resistance.
No, doctor, no imipenem.
So imipenem, how do you fortify or how do you make into topical?
So in our group, only one patient needed imipenem. So from intravenous preparation, we diluted with a normal saline and prepared it, and with the lifespan of only 1 week.
In these patients, all of them were from trauma history, or they had a history of some other?
No, doctor. Mostly patients have a history of trauma, but some patients have a history of contact lens use and poor ocular surface, and where Sherman's was less than 5 mm. And Mainly
So
trauma was the most common.
Pseudomonas is one of the most common as a hospital-acquired infection.
Yes, doctor.
But when it is trauma, the other range of organisms are more common.
Yes, doctor. In the previous study by Dr. Vazirani and all, in their group they found contact lens use a most common factor. But in our study we found trauma as the most common risk factor.
We'll move to our last talk for this.